So, as with many areas of speech and language therapy, there are gaps in our knowledge of the evidence base about how speech and language therapists can best support children and adults with learning disabilities across their lifespan. And these gaps exist in our knowledge relating to both communication and swallowing difficulties in the population. So in areas where there are lots of gaps to fill, research priority setting partnerships can be used to generate topics or questions that are agreed to be the priority for research and allow us to direct and inform future research within an area. And in particular, these research priorities can enable us to influence funding bodies such as the National Institute for Health and Care Research to fund more research into a specific area. They can enable us to influence policymakers about gaps in the evidence and the importance of learning disability research. And they can also highlight where gaps in our knowledge exist for and promote networks and support groups to enable us to complete this research and get the answers we need to these important questions. So back in February 2019, the RCSLT used an adapted James Lind Alliance research priority setting partnership to identify a long list of research priorities and the top 10 research priorities for learning disabilities and research for speech and language therapy. So some of you may have been involved in this work, which involved a survey of speech and language therapists, multi-stakeholder workshops, an online card sort activity, and input from individuals with learning disabilities, and very much incorporated the principles of the James Lind Alliance, which includes engaging the end users of research to help direct funding to their areas of greatest need. So just zoomed in here on the top 3 priorities that came out of the top 10 list. And you might be able to see that from these, that whilst these research priorities very much identified priorities as part of the process that very much reflected issues that are relevant and meaningful to those involved, they were not specifically worded questions that researchers or research funders could immediately work with and take forward. And this is quite common to lots of research priority setting partnerships that have been done before. And in some senses, identifying research priority areas can just be the start of this important work.
Amount of overlap in what we do and our approach.
So in March 2020, colleagues met with the working group of the original research priority setting partnership to agree on what should be the next steps for creating impact from these research priorities. And it was at this stage where it was agreed there was a need to carry on with this work as part of a translation phase to generate these research priority areas into more specific research questions. However, there's been limited literature published which explicitly kind of presents robust and replicable methods to translate priority areas into fundable research questions. And in the literature, translating research priority topics into these fundable questions has been described as quite a challenging process. So from March 2020 to April 2021, I did some work talking with key stakeholders, such as funders, such as the NIHR, co-producing with a speech and language therapist and researcher, and incorporating the views of individuals with lived experience to put together methods and protocol to develop a translation. Millie, you're muted.
Yeah, you've accidentally muted yourself, I think, because you've moved the slides.
Oh, is that better?
Yeah.
Sorry. So the aim of this work was to identify research priorities from the original long list of research priority areas that were published in the first phase. And the reason to go back to this long list of priorities was that we very much acknowledged that these were published in 2019 and with the COVID-19 pandemic and things changing between the year of 2019 to 2021. And we wanted to make sure that the priorities really kind of represented what was important now within the context that we were working with. And then we wanted to use these priorities to generate specific answerable research questions with input from people with lived experience. So how did we do this then? So this study used a participatory design aligning with principles from the JLA methodology for setting research priorities, which are to support inclusivity, to use transparent reporting methods, and to commit to using and contributing to the evidence base. And we developed a protocol with input from 8 adults with learning disabilities, a researcher and speech and language therapists who specialise working with people with learning disabilities. And we recruited some subgroups of 8 experienced researchers, 15 speech and language therapists, a psychology researcher, and 1 student speech and language therapist. And with this group of people, we had an initial project meeting to introduce the researchers, speech and language therapists to the project, give an overview of the protocol, and to allow us to split the groups of researchers and speech and language therapists into subgroups based on their experiences and interests. We then asked the subgroups to systematically review the original long list of priorities and identify which areas remain a priority based on current clinical, political, and social contexts. And then we asked the subgroups to incorporate the best available research evidence, service user views, and to value expert opinion as per the 3 pillars of evidence-based practice triad. So we asked the researchers to find relevant literature related to the topic to see whether the priority had already been answered or what further research would move our knowledge on in this area. We ask speech and language therapists to give their view on what happens on the ground. And where possible, we ask the speech and language therapists and researchers to incorporate views of individuals with lived experiences, including people with learning disabilities and their supporters. And then we ask the subgroups to kind of generate and use all this information to generate research questions that could be taken forward to funders or used to support future research in the area. So what did we find then? So we had an original long list of 87 priorities, which were condensed into 18 top priorities based on the top 10 list of research priorities that were produced in phase 1, and those determined by researchers and speech and language therapists working in the expert field as being clinically, socially, or politically relevant at the time. And these priorities related to the following areas. So the role of the speech and language therapist, service delivery, information gathering and assessment, environment and staff around the individual, communication partners, dysphagia and AAC. In each of those areas, the researchers were able to summarise the research, key papers found, and what research is required to move kind of the evidence forward in this area. And this was documented and collated into a table. And then within each of the subgroups, there was a varying level of ability to integrate the views and values of people with learning disabilities, their carers and family members. And this was based on who each of the subgroups were able to involve at the time. And we asked each of the subgroups to record this information on an adapted GRIP2 reporting form, which is a really useful tool for recording patient and public involvement input. So from all of this work, 29 research questions were then generated, and I've put a link to the RCSLT website where a full list of these questions can be found, and I've just added a few of the kind of key research questions that were generated as part of this process. And you might be able to see that the research questions generated were quite diverse in nature, which allow for a range of methods to be used to address them, and therefore they're likely to be appropriate for lots of different funding streams. Some groups in particular felt that priorities were quite broad and therefore split them into multiple questions. And in 2 areas, it was agreed that kind of no further research was needed, and we just had a summary of the research that was already available in the area. They encourage you to look at the RCSLT website for more information about this project. It's been published in an RCSLT publication and an easy read format and video. And I've just put a link there, or a summary of the first research priority setting partnership project, which has been published in the TISARD Learning Disability journal. So overall then, this work has provided a protocol for which research priority setting areas originating from a research priority setting partnership can be translated into specific research questions. And this was involved by collaborating with individuals with lived experiences. Secondly, this work has provided us with an overview of current research relating to the 18 priority areas set in the Learning Disabilities Research Priority Setting project. And thirdly, this has allowed us to identify 29 specific research questions that can be potentially taken forward for research funders such as the National Institute of Health and Care Research. So thank you very much for listening. I'm glad we got there in the end. And these are a few kind of next steps that you could take in terms of engaging with research priority setting research questions that have been produced as part of this work. And a list of all of those involved, because it's very much been a team effort. So thank you.
Millie, thank you very much. We were all kept waiting a long time. Welcome everybody who's been joining as you went, as Millie was presenting there. We have recorded the session, and so we will find a way of making that available to you. If people want to put questions in the chat for Millie, please do that. We will leave some time for questions at the end, but I think we'll go straight on. Sian, are you okay to go next?
Yeah.
Can somebody else monitor the admitting people whilst you're presenting?
Yes, my colleague, I was going to say Faye in the background, has been busy helping out admitting people.
Okay.
So she'll be continuing with that, hopefully.
All right, lovely. So without further ado, here is Sian Wood, and Sian's going to be talking about the communication profile intervention. Sian, I will give you a 1-minute warning if you need it.
Super. Well, I was thinking, how can I slim it down when people's got their time? I'm already talking about a 4-year PhD project in 14 minutes, so I'm not sure I managed to trim that much off. I will do my best.
I don't think you need to worry.
Okay.
I think go for your 14 minutes, and if people don't have time for questions at the end, people can email you, but I think you should do your presentation as you planned it.
Sure. Okay. I will try my best. Okay, so I'm Sian and I work in a large mental health and intellectual disabilities NHS trust in the East Midlands, and since 2019, alongside my clinical work, I've also been undertaking a PhD at the University of Sheffield with Professor Judy Clegg and Dr. Sarah Spencer, and that's aiming to develop and test an SLT behaviour change intervention, encouraging paid carers to adjust their communication to match the needs of the adults with intellectual disabilities they support. So we all know that communication skills are foundational for inclusion, control and well-being, yet a very high percentage of people with intellectual disabilities experience communication challenge. And as SLTs, we work with adults with ID and their primary communication partners using a range of approaches aiming to improve communication. But the evidence around effectiveness for SLT intervention in this context is poor. So a systematic review I undertook leading up to this project found that the evidence that is available doesn't reflect current practice very closely, with the focus being more on direct interventions targeting the individual skills rather than the more frequently used approach of working with carers to support them to adopt optimal communication strategies in practice. So additional research into the types of interventions frequently used in clinical practice is essential to support us all to be able to make evidence-based practice decisions. So one commonly adopted SLT intervention in adult ID services in the UK is communication profiles, which aim to summarise and share complex information about an individual's communication. And generally, following assessment, the communication profile may function as an accessible speech and language therapy report and contains individual communication strategy recommendations. Many recommendations require the individual's communication partner, frequently paid carers, to make communication behaviour changes, such as using easier language or adopting augmentative and alternative communication. When the profiles shared with carers, they're often supported to implement the strategies through training and modelling. And we know anecdotally that these approaches are widely used and well liked by carers and professionals, but provisional evidence suggests that having documented communication strategy recommendations doesn't lead to change in communication, perhaps communication partner behaviour, and is therefore it's not associated with receiving better communication support. Excuse me. It's perhaps not surprising because we all know that telling people what to do doesn't mean that they'll automatically do it. We only have to think about the eat less and move more guidance to appreciate that. And making changes can obviously be difficult, especially when you're making a change to your communication to benefit someone else. So our research project is focusing on looking at what support is needed to help paid carers to make the communication behaviour changes. For example, if we were advising them to use signing or gesture when communicating with someone, what SLT input can be provided to increase the chances that they'll actually do this? So at the start of this project, some preliminary consensus work was required due to the range of communication profiling approaches used by SLT services across the UK, which are quite poorly defined and delivered variably. So a nominal group technique was adopted with an expert panel of SLTs from the RCSLT ALD Leeds network, and that led to some consensus statements about terminology and core components of key profiling approaches. So this helped to establish what was meant when we were discussing communication profiles as opposed to communication passports or communication dictionaries, and it clarified the typical format of the documentation. However, it wasn't able to define the nature, frequency or intensity of any SLT input provided as part of the intervention to support the implementation of the recommended communication strategies. So this work was undertaken in phase 2 of the project, the intervention development stage. So the research aim for phase 2 was to use a theoretically driven approach informed by stakeholders to develop an intervention that focuses on increasing paid carers' use of communication strategies outlined in an individual's communication profile. As the goal of the intervention is for paid carer communication partners to change their communication behaviour to meet the needs of the individual they support, it's a behaviour change intervention, and as such, the intervention development process was guided by the behaviour change theory. So the theoretical domain framework and the capability, opportunity, motivation, behaviour or COM-B model are the key behavioural science theoretical frameworks used within this project. They form central pieces of the behaviour change wheel which guided the intervention development process within the overarching Medical Research Council framework. The starting point for this project was to articulate the problem, define the target behaviour and identify what needed to change to achieve this. To establish what needed to change and complete a behavioural diagnosis, we combined evidence from a literature review looking at barriers to paid carers implementing speech and language therapy recommendations along with an interview study. So the interview study aimed to explore and identify barriers and facilitators to paid carers' use of communication strategies from the perspectives of both paid carers and speech and language therapists working in adult ID services. In-depth one-to-one semi-structured virtual interviews were completed with 13 participants, so 6 paid carers and 7 SLTs working in ID services. And the theoretical domains framework and the COM-B model guided the interview schedule and the analysis. All 3 domains of capability, opportunity and motivation were found to be implicated in barrier behaviour, but this study found that the primary barriers to paid carers implementing communication strategies fell within the knowledge, beliefs about consequences, environmental context and resources domains. And the most discussed individual barrier was insufficient specialist communication support for carers to learn how to use the communication strategies and share these approaches with others. So insights gained from this study were combined with findings from the literature review to provide a synthesised summary or behavioural diagnosis of the key barriers and facilitators. So from this list, intervention targets were developed to address each barrier felt to be at least partially within the speech and language therapy control. The next step in the process involved turning the targets into an intervention designed to address these, and having completed the behavioural diagnosis user in the TDF, it was possible to use a matrix resource called the Therian Technique online tool to select theoretically sound behaviour change techniques referred to as the smallest ingredients in an intervention. And we undertook quite a lengthy shortlisting process with stakeholders, and the top ranking behaviour change techniques were then prioritised for inclusion in the intervention, and they were incorporated into each relevant intervention target. So the Tidier checklist was used to capture all of the key dimensions when describing the intervention, and then detail of each session, it was outlined in an intervention guide. So a prerequisite for this intervention is that before beginning, a communication profile containing clear individualised communication strategy recommendations needs to have been completed. The intervention then focuses on helping carers to understand these recommendations and use them in practice. And the endpoint intervention included 8 sessions, which incorporated management and peer support, training, modelling, coaching, practice, and some video reflection to support communication behaviour change. The final phase of the research has involved testing the intervention in clinical practice using a non-concurrent multiple probe across participants study. So 3 pairs of paid carer participants, 6 participants in total, were recruited from a community RCSLT communication waiting list. And each participant pair supported an individual with ID and additional communication difficulties. There were no restrictions on the individual's presentation, but the recruitment criteria did require there to be a stable staffing team in the primary setting and management support. NHS ethical approval was gained, and in all 3 cases, additionally, in addition to explaining the intervention and research project to the individuals with intellectual disabilities, personal consultee agreement was provided. The 3 individuals who were supported by the 6 participants had wide-ranging communication skills and needs, and each had a number of communication strategy recommendations in their communication profiles. And during the initial sessions, the participant pairs each selected which 2 communication strategies they wanted to focus on during the project. And in this study, each paid carer participant served as their own control, and measures of the target outcome, which was participants' use of the selected communication strategies, were taken repeatedly at baseline and during the intervention. So multiple 5-minute video clips of the participant and individual with communication needs interacting in the usual setting were analysed, comparing opportunities to use the strategies with actual strategy use. In addition, a number of secondary outcomes included a knowledge and skills questionnaire, participant rated self-efficacy, clinician reported outcome measures, and the individual's perspectives using talking mats, which were captured pre and post intervention. So all data has now been collected and is currently being analysed. I'll briefly share some draft findings from the first stage of analysis, but it's important to highlight that these are not finalised. So completed data for the main outcome is only available for 4 out of the 6 participants currently, and a second rater still needs to review the footage blind to the intervention stage. But the provisional findings do suggest that the paid carer participants' use of communication strategies improves during the intervention, with the improvement being sustained at a 6-week review stage. The level of improvement varies considerably by individual participant and by strategy type, so it will require further analysis. Additionally, participants' communication knowledge and skills levels were wide-ranging, but they also showed improvement pre and post. And finally, paid carer participants' self-belief in their ability to support the individual's communication also showed positive change. All participants felt more able to manage any communication difficulties they faced, but an interesting finding was noted on the self-efficacy questionnaire, where 2 participants who both supported the same individual reported an increase in severity of the individual's communication difficulties over the course of the intervention. And for these participants, it appears that the intervention had changed their perception of the individual they support, who was verbally able but had significant processing and comprehension difficulties. And it had highlighted the communication needs that they had not felt were there initially. On completion of the intervention, participants' views about the process and its acceptability were gathered via a questionnaire. All participants reported their involvement in the process positively. One participant did, however, identify that there was potentially some difficulty in terms of the time commitment required, which is an important factor to be mindful of when considering feasibility within services. And additionally, qualitative feedback highlighted the importance of establishing positive relationships, the benefit of the peer support role, so having another staff member going through the process with you and being able to practice outside of any SLT time, and also the value in the joint discovery process, being able to feel vulnerable and not having to know the answers. So, to summarise, the projects involved working with stakeholders all the way through to develop a behaviour change intervention designed to support paid carers to increase their use of individualised communication strategies that's feasible to deliver in practice. On initial testing, it appears that the additional support provided as part of the SLT intervention does result in an increase in strategy use by paid carers. As this intervention has similarities with what lots of SLTs are doing in clinical practice already, hopefully it can provide provisional evidence that SLT input with communication partners in ID services can be effective. However, it's a very small scale project and further replications and findings are required before any conclusions can be drawn. And further, it's not possible for this project to know what parts of the intervention are responsible for what elements of change and what additional factors may influence the outcome. So further robust research is clearly required. And to finish, I was just going to share a few reflections from my personal experience of developing and delivering this intervention. But I'm very conscious of time, so I'll just end with maybe a slightly ironic point.
You've got a minute. You've got a minute.
Right. Well,
yeah.
I'll end. There were a number of them. I will end with the main one, which for me was around the time. So I realised what I'd enjoyed most about delivering the intervention was the fact that it had enabled me to spend more time getting to know the individuals, more than I would have typically done in my contact for referrals. And we know time is limited for SLTs and carers, so even an 8-session SLT intervention can feel very time intensive in a community setting, particularly with the level of planning and preparation required to help each session be as effective as possible. And when I shared with the ALD Leeds network, about 50% felt that 8 sessions was too much and that their service wouldn't be able to manage it. About 50% felt that it was feasible within service. But I think my main reflection is we can't expect to achieve change through reports or one-off training sessions alone. So we need to challenge ourselves to ask what impact our input is having and think about what communication therapy in adult ID services is and should look like. So even if it's not possible now within resource pressures, we know what we want our services to look like, because there's a sense that we move towards assessment and advice and we lose some of the therapy element. And actually it is that contact and support and coaching that often is the element that makes a change. Okay. That is it. Thank you.
Sian, thank you so much, and bang on time.
Oh,
so well done for that. I suggest we move on. Nicola, do you want a little bit of time to get your slides shared? Oh, you're on mute, Nicola. You're still on, you're off muted now. Go on. Oh, no sound. You've unmuted yourself, but we've got no sound. Leave the meeting and come back in again. It's always worth a try. Well, sorry, everybody. I wonder if people have got any questions while Nicola is just getting set up, either for Millie or for Sian. If you've got a question, perhaps just put your hand up.
Hear me now?
Yes.
Well, that's a relief. Right. Now, the next thing is, how do I share my screen?
So next to the leave button, don't click on the leave button. There is a box that says share.
Okay, screen, window or tab?
Oh,
I'd go with window.
Okay.
And then you should be able to, have you got like a PowerPoint or something like that? You should be able to see.
Wow, Sian, this is just amazing. You see, right, and it says thanks for listening, but we haven't got there yet.
no.
So
It's up now though, we can see it, so that's a good.
yeah, okay. Can
Right,
you see
thank
that?
you so much. Delighted to introduce Nicola Grove, who's going to be talking about story sharing and co-telling stories of personal experience. Nicola, I will give you a 1-minute warning.
Thank you very much indeed. Following the example given at the keynote this morning, you can't actually see me, but I'm a white woman with grey highlights in my grey hair, and I'm wearing purple like the poem. I've been in SLT for 47 years, although I'm retired now, and I have always worked with people with severe and profound disabilities. And I would say in that time, my relationship has really shifted from being that of a professional and a client, or patient, if you like, to colleague and ally in a shared endeavour to explore ways of effectively communicating together. It's very influenced by the work that I now do with self-advocates. So I was very happy to see the themes of this conference. This focus on capability, on affirmation of all types of neurodiversity and co-production, a kind of quite hard one for me, I would say, over nearly 50 years of practice, and I'm definitely not there yet. But I think for all of us, the goal of those processes, if you like, have to be inclusion. And in this talk, I'm going to focus on two aspects, one being friendship, the other being citizenship. It was great to hear Robert Buckland this morning talking about universality. So the principle of universal design is that if you want to be maximally inclusive, then you should start with the hardest to reach group. And I think there's no argument that one of the hardest challenges is faced in trying to develop inclusive practice with people who have profound and multiple disabilities. So let's have a little bit of a look at why that is. So I would say that in the 50 years I've been working with this group of people, although there have been some fantastic initiatives, largely aimed at individuals and groups, such as, for example, intensive interaction and sensory approaches, multisensory storytelling, attunement, objects of reference. As regards their position in wider society, that has hardly shifted at all. And these are some recent findings which demonstrate the problems that they have in those areas of making friends and of taking part as citizens. They are largely excluded from processes of knowledge production, and they're still seen really as vulnerable victims, and sometimes shockingly as people whose lives are not worth living. Now, one of the major barriers, of course, is communication, which places particular responsibility on us as speech and language therapists. As is well known, this population largely function at a pre-verbal level of communication and have complex health needs and motor and sensory impairments that can make it difficult for them to attend and interact, and for us to find the right ways of communicating with them. But I think it's really time for a paradigm shift, and I'm very grateful to my colleagues PANIS, whom I work very closely with, for these insights into how people with profound disabilities can be our teachers. And certainly that's been the case for me. These are the people that I have learned the most from. There's another, I think, very revolutionary turn with the findings of Mark Solms, who's the only neuropsychologist I know who puts people with profound disabilities at the absolute center of his work. So he looked at the issue of what is consciousness for an anencephalic child, and his findings in his model emphasizes that emotional consciousness operates at a subcortical level and is just as important as what we might call the thinking brain or cortical consciousness. And it's feelings that in fact enable learning, memory, and predictions. You can see I've put the link to the webinar that he gave for us last year in the references at the end of the talk. We also know that there are some programs that do seem to have some positive indications about inclusion in wider society. MENCAP ran the Involve Me project for 3 years, and I was lucky enough to be involved. And story sharing was one of the programs independently evaluated, and of course that's what I'm talking about. So why story? Well, again, I'm grateful to Robert Buckland in his keynote for expressing far better than I can why we need stories, and why storytelling is one of the main ways that we can break down these barriers. And this infographic, I think, illustrates this kind of cycle, if you like, whereby you really, the way that we make and sustain relationships is by sharing experiences in the form of stories. And sharing stories actually changes the way that people see us. And that's because of the way we know that when we are telling a story, our brains come into synchrony as listeners and tellers, and that changes the way people are seen, and that in turn expands the stories that they have to tell and their sense of who they are. However, if we're going to use story with this group, we really, as speech and language therapists, I think, have to adopt a much broader understanding of what story is than is usual. Now, typically we think of narrative as a high-level complex discourse skill that involves the manipulation of structural elements in sequence, largely told as a monologue. And in fact, that's explicit in the SKIP program, for example, which is a brilliant program. But that's not the whole story. And indeed, William Leboeuf, who's one of the leading narrative researchers, says that if you only do that, if you only provide structural elements, you are doing nothing more than giving a shopping list of events. Because in order to make a narrative into a story, you have to have what he terms evaluation, this dimension, which includes not only explicit judgments, that of course are high-level linguistic skills, but affective elements that develop very early in communication, as we know from the work of Colwyn Trevarthen and Michael Tomasello. And these affective elements and the rhythmic patterning, the prosody, the nonverbal, the way that you communicate emotions are what signal to the listener the meaning of the story and why they should be listening to it. And these are not things that we leave behind. We need these. These are the foundations of narrative, and these are the aspects that are, in fact, accessible to people with profound disabilities. So very briefly about story sharing, I haven't got time to go into it, but there's a lot of information on the website. It started because when I was working 21 years ago in a day centre, I noticed how often staff told stories about the people they were looking after and never, ever with them. And with the staff and with the members of that centre, we started exploring ways of doing that, and story sharing as a program was the result. It draws on a whole body of research and narrative practice known as small stories, which are these tiny anecdotes, often overlooked, that arise in conversation, are told repeatedly, and which are embodied. So let's look at story sharing in action. And this is a little film of Lucy Cook, story sharing tutor, and her student Mariam. And it's a tiny little story told in class that I think exemplifies some of the things that we're trying to get at in our practice and that we would want as speech therapists to be happening for our allies with profound disabilities. So here we go, it's 2 minutes long.
Yeah.
Marianne went shopping. Shopping for some shoes. Some new shoes. The shop assistant brought out box number 1. And in the box there were shoes, gold, sparkling shoes. The lady in the shop said,
Maybe you should try both.
maybe you should try both. And Marianne nodded her head. Yes. She nodded her head to say yes. Marianne said, "Aja, aja." Come here. Look at my new shoes.
Now, it's really interesting when I look at that video, which I've done a lot. It's easy to get distracted by Miriam's involuntary vocalizations and some of her movements. But when I pulled stills out, I think what was really noticeable was how natural her body language is when you look at it. It also demonstrates the number of ways that she is contributing to the story. And as she tells that story more and more, she will do this more and more fluently. But if you look at how she uses eye gaze, the number of things she's able to manipulate, the way that she can reach out, and this final image, which you didn't see, but which is the final picture of the film, which I really, really love, because in our societies, when you lean back like this at the end of an anecdote, it is a very typical way that you signal that you have come to the end of your story. And through mirroring those behaviors, Mariam is learning and giving that pragmatic cue. Now, what are the stories to do with...
Nicola, you've got 1 minute left.
Perfect. Inclusion and friendship. Well, friendship, she's a teenage girl who is able to share with her peers a story about getting new shoes, what's not to like. In terms of citizenship, I think it's really moving and meaningful that she can go to an ordinary shop and have a shopkeeper treat her as a valued customer. These tiny things are what give a sense of belonging. So what can you do as a result of this? Go away and look at narrative culture in the places where you work. Particularly, where are the stories? Who owns them? Are they told about, to, and for, or are they told with and by? And this is a great example of active narrative culture from One Trust Centre in South London, where everybody is participating in the tiny story of how Gary goes and gets a haircut. And because everybody is so engaged, that motivates Gary to use the Big Mac and to actually touch his hair. This is more communication than anybody has ever seen from Gary. So thank you very much for listening. Storytelling training is provided by PAMIS. You can find out a lot more at the website, and please do email me for further information. And my thanks and acknowledgement to all the people who've taken part. And that is a list of references. Thank you.
Thank you. Thank you very much, Nicola. Can I ask you to stop the share?
Yes, if I can work out how to do it.
So you should be able to go back to the button. Wonderful.
I've done it.
Great. Well done. Thank you very much. Thank you very much, everybody. I know that our timings were spot on, but the session obviously started very late. If anybody does need to go, then that's absolutely fine. Please do put your questions in the chat, and I wondered if we could just take a few minutes to pick up on the questions that have been asked. Sian, there's been a couple of questions for you. I don't know whether you've been keeping an eye on the chat, but there are a couple of questions, and I don't know whether you want to well, I'll just pick one of them randomly. Yeah. And so Catherine Broomfield says it's a brilliant study and lots of work. And she says there are lots of sessions in the conference on dosage and intensity of therapy for impact. Do you think we need to reconsider our service offers in light of the evidence base? And if so, do you have any ideas or experience about how these conversations can start?
Yes, so I did spot that one, and I think that's kind of how the motivation for a lot of this started. That attending meetings back then, which used to have kind of quite regularly with commissioners and having those discussions. And when you're squeezed and arguing against the fact that you might be being pushed more towards an assessment and advice service, it's really hard when we don't have evidence to support. So we can say clearly there's a need and we know that additional inputs required. And Susan makes another point in the chat I've just spotted then, which is related, that actually sometimes it's required and required again because of the turnover of the staff within this service. And sometimes we certainly used to in our service have a sense where if somebody's been seen and they've got a communication profile report, whatever, then just send that out to the service again without thinking about the support package that needs to go around it. So the project started out just trying to really begin to get some sort of evidence to take in to discuss with the commissioners about what, and your study, Jill, was actually brilliantly timed in terms of looking at the fact that a number of people had really good communication passports or reports, but that didn't change staff behaviour. So it's about trying to build on that to have those discussions when you have the opportunities, I think, with commissioners. And it's SLT, it's the same, isn't it? Right across the board, as Catherine says there, the dosing issue is huge, and where kind of this notional 6 sessions might come from in children's services, and we're the same in adults. We're all pushed to deliver on a small numbers, but we need to have some sort of provisional evidence to say, well, that on itself won't work. What does work and how much, when whether you get far more effective output by doing more, can only come by doing more projects. I don't know if that answers the question, sorry, but
it's really helpful. It's really helpful. I'm sure that the conversation will continue offline. Millie, I think you're still here. I had a question for you, Millie. I wondered whether you might reflect on what had surprised you most about if anything, about the research questions that had been generated.
Yeah, sorry, I don't know why my camera's not working. I just add to the tech issues. Yeah, so I think actually from talking with people, so we quite interestingly, in the top 10 priorities of the kind of original priority setting partnership, I think it was about 4 or 5 of them related to dysphagia. And I think that's really why we wanted to go back to that original long list of priorities to actually consider what are the other research priority areas out there in relation to communication, and where do we need to start with that? And I think what speech and language therapists were telling us on the ground was actually that communication services were the ones that were being stopped or kind of not prioritised as much as the dysphagia services. So that's gave us a really good indicator to think actually we need to go back to the original priority list and figure out where do we need to support communication research as well as kind of prioritising eating, drinking and swallowing difficulties as well. So I think getting that balance was really important and something that had come out as part of the priorities. And actually, I think one of the questions was around actually we need to know about what is the prevalence of communication and swallowing difficulties in this population as a good start as well, and how important that data will be to support commissioners and to support us to get the services that we need in learning disabilities and speech therapy settings.
Thank you, Millie, that's really helpful. And then Nicola, I wonder if you might perhaps end the question and answer session. And I wondered, you reflected looking back in terms of how much the profession had changed and the way in which your engagement and working with people had changed. I wonder if you could do as a look forward and what still needs to happen and how do we support that? So just a really easy question for you to end on.
Oh God, I love that. I was actually thinking about that. Okay, I mean, I've actually employed people with profound disabilities as teachers and consultants. And that's what we're aiming to do at the RICS, where I'm now a professor of inclusive research. So that's, I think, actually, really, I also run with the OU a session on big ideas, which is accessible theory for co-researchers and activists. And I think it's about going forward together with the people we work with so that we really take co-production seriously with all of the individuals that we work with, because we can all learn so much. I'm really humbled by what I learn from, well, all of my colleagues, I mean, all of you guys today, but with the people with profound disabilities that I work with, and it's of course their families as well, but it's those individuals who teach me what communication is, how there are no limits on communication, there are no limits on inclusion, and we've got to start breaking down, I think. I mean, I'm a bit iconoclastic here. I can't bear this. I'm really not comfortable with a medical model, with seeing myself as a speech therapist, as some kind of doctor or healer or rescuer. It's about how we treat each problem that comes up and we're presented with as an incredibly exciting opportunity to find out more about ourselves, more about what our profession can do to change, and more about how we go forward together and treating people as citizens who have something to offer. Is that no? I could go on.
Nicola, that's fantastic. Thank you all so much. Can we just have a round of applause for our excellent presentations and for our speakers? Perhaps just unmute yourselves just for a moment. Thank you so much. So huge, thank you. Huge apologies. No idea what went wrong with the tech. Or why we had to move platforms. Sorry, can people mute themselves again? Thank you. So Sian, you have very kindly recorded this session for us, and Jess, you have been in touch, I think, with RCSLT about how we can share that session, and I wonder, Sian, whether we can make sure we record and share the meeting chat as well, because I think there have been some interesting conversations that have been generated within that. So well done all. Thank you very much for your patience and for finding your way over to Teams. I think, Nicola, the idea of us jumping ship and doing something creative might originally have come from you, and so thank you very much for that. And to Sian and colleagues for following through on that and setting that up. It's been really great to have some time focusing on people with learning disabilities.
Can I just say, oh my God, do you mean that this whole initiative came from Sian, not from the tech people?
Well, it was your idea, I think, Nicola.
I was going to say it was your idea that we just jumped on and thought, let's not wait.
Oh my God!
You know, this has just all been generated from you. You, I think, slightly sarcastically, perhaps saying, why don't we jump ship? And then us all going, oh, that's a fine idea. So no, I don't know about anybody else, but I don't think we've had any communication from the conference people. But anyway, we've got it to work and we've had a great session. So well done all.
Thanks for great sharing, Jill.
You're welcome.
And I just want to say hello to Catherine, who is a total inspiration. She and her daughter, huge inspiration. Catherine de House, doing a PhD at the moment. Fabulous to see you here, colleague, friend.
Hello, Nicola. Nice to see you.
And you.
Thanks, everybody. Sian and Jess, can I leave you to liaise around the technical aspects of that? Well done, everybody. Enjoy the rest of the conference. Bye.